Okay. Just because of the way chapter 43 is set up, it's not going to talk about cirrhosis and then go to the complications. So it starts with the complications. So we'll do it a different way. Let's start with an overview of the condition first. So this is Stevens. This is Stevens' esophagus. This is her stomach. And this is her liver right here. And of course, there are small bowels here. Okay, and her heart is somewhere here. And that means this is her inferior vena cava and the two lungs here. Right. Not bad, yeah? Okay. Okay. So how the physiology works is, so all the blood returning to the heart before it enters the inferior vena cava, they have to pass through the liver. So organs beginning with the esophagus down to your toes, all that blood as they enter the venous circulation and then enter the heart, before they reach the inferior vena cava, they have to enter the portal circulation. So what happens during that entry? So the liver does its job as blood enters it. Let's just mention four important ones. Of course, the liver performs many other functions, but major ones we'll talk about today for purposes of the discussion and testing. Number one is drug and other food metabolism. This will also include protein synthesis, meaning the liver is responsible for metabolizing albumin. Albumin, of course, as you know, is responsible for holding water in the plasma, correct? So our blood has a specific volume because of protein, because of albumin. And you're also aware that the liver makes clotting factors, correct? Using vitamin K. And it's also, of course, responsible for making bile, yeah, for digestion. And then finally for ammonia elimination. Right? So since it has something to do with bile, so therefore when the liver bile production, so when the liver fails, therefore can it still make bile? No. So what happens to bilirubin levels? And then what will happen to the color of the skin? So we have jaundice and etc. Right. So let's start. We have drug metabolism, protein. Yeah, protein synthesis, clotting factors, production, and of course ammonia elimination. There are, like I said, like glycogen, for instance, is stored in the liver, right? And various other functions. So with metabolism, that means what happens to the body's ability to metabolize drugs. Okay, so therefore it will limit our choices, correct? So we have to limit the amount of drugs we can give the patient and what type of drugs we can give, correct? Okay, so because of this setup, so we have all the organs starting from the esophagus down to your toes. As that all that blood enters the venous circulation, they have to pass through liver. Okay, so who are not familiar with liver tissue at the grocery? Who has not seen liver at the grocery? No, the liver tissue from pork or beef liver. You know what it is, right? Even if you don't eat it, you know what it is. Okay. Yeah, so it looks smooth. Like what color is it? Very red. Yeah. Okay. Why is it very red? Like steak is very red. Why is liver very red? Okay, it has very rich blood supply. Okay, so when you cut liver, it bleeds, right? Because it's very, very vascular. So you can say the liver is a wonderful organ. Okay, and no matter how sick it is, so let's say because there are three basic causes of liver disease. So how do you destroy your liver? In one of three ways. Okay. So we'll talk about hepatitis. That's okay. We'll discuss hepatitis separately. Okay, so we have alcohol, or also called Lennox cirrhosis, Laennec, Lennox cirrhosis. That's basically alcohol cirrhosis. Next is biliary obstruction. Like if you have most common causes, you had a gallstone, gallbladder stone that obstructed, affected your pancreas, and then eventually affected your liver. And finally, hepatitis, viral or other forms of hepatitis. Okay, so let's take any one of these. So when we say cirrhosis, that means end-stage liver disease. So what happens basically is it's like putting your liver, you put soy sauce or some salt on it and put it on a grill, even just 1 to 2 minutes for each side. Put it on the grill for 1 minute, turn it over. So is it still red, squishy, and soft? No, it's now shrunken, correct? Okay, so what happens to all the blood vessels that's inside it? If that's what you did with your liver, either through alcohol, biliary obstruction, or hepatitis. Okay, so it's now all shrunken, correct? So the blood vessels are now so narrow. Okay, so let's go back here in your anatomy. So what happens to all that blood that's gonna pass through the liver before entering the heart? All right, so is there still good metabolism of whatever's in it? You still have good protein synthesis. Okay, so let's talk about protein synthesis. So since albumin is responsible for holding water in the blood, so that the water doesn't go elsewhere, it stays in the bloodstream, in the plasma. If protein levels are low, can can water still stay in the intravascular compartment? Because now the osmotic concentration is now different, right? So the blood is no longer higher in concentration compared to the cell. So osmosis sets in, right? Osmosis says, where will water go? So an area of greater concentration. So now there's an imbalance because you have lower protein levels in the plasma. So now they will go out of the bloodstream. Go where? In the legs, in the stomach. Okay, so this patient will have a big belly, okay, fluid accumulation in the peritoneum, and then legs will also be very big. Okay, so all the edema is caused by decreased protein levels in the body. All right, so now the patient also has a decreased production of clotting factors, correct? Because you need protein to make clotting factors, right? In addition to vitamin K. So what happens to the patient's bleeding time? PT, INR, PTT. All what? Increased or decreased? Clotting factors are decreased. Roselle? It will increase bleeding time. So is the patient at risk for bleeding or at risk for clotting? Increased risk for bleeding. Then ammonia. So ammonia is a nitrogenous waste product. So it's directly related to protein levels. So if you have higher protein, of course, you have higher ammonia to eliminate, correct? All right, so now the liver is diseased. You cannot normally eliminate ammonia. So does it accumulate in the bloodstream? Does it cause toxicity? Does it cause brain damage? Yes, we call that encephalopathy. So that will be our last topic under cirrhosis. Right. Okay. So let's go back here. So now the one thing wonderful about the liver is no matter how diseased it is, even if it's just 5 or 10% functional, that 5 to 10% will work. Okay? It will continue to do drug metabolism, protein synthesis, make clotting factors, eliminate ammonia. Okay? No matter how small the remaining functional cells are, right? So you can't really say, oh, that liver's no good. It's still good. Okay? No matter if it's 5%, 2%, 1%, it's 1% good. It's 2% good, 5% good. But of course, can we say it's compatible with life? Of course not. Okay, so there will be consequences as a result, right? But it still works. All right. All right. So let's now discuss what will be consequences when the patient's liver is diseased. So now we go through the chapter. Okay, let's start with jaundice. So what is jaundice? Yellowing of the skin and the sclera. All right. And what is now the color of the stool also? Okay, so here the first paragraph explains that. So this is now no, the stool actually has no, it'll be pale in color because Billy and Ruben, there's two parts of it. So here, if urobilinogen is absent from the urine and decreased in the stool, it would change the color. So that's this substance gives the urine its yellow color and the stool is brown color, right? So that's why even if you're eating, have you ever noticed you eat, is the food you eat brown? No, there's no brown, nothing brown about vanilla ice cream, yeah? But why does it turn brown when it comes out? It's the urobilinogen, okay? That's how we eliminate bilirubin. So it's nothing is wasted in the body basically. So we recycle everything before we eliminate it. So during the recycling in the spleen, so that's what we use it for. So we use it to color the urine and color the stool. All right. Mm-hmm. Anyway, that's just something to think about. It's not really testable, right? Okay, so of course, and in the elimination, of course, this will be stuck in the skin pigmentation. So that's why our sclera, the whites of our eyes turn yellow, skin turns yellow, and then in the urine. So what's the color of the urine now? Is it still yellow? It'll be darker now. Okay, so the urine will now look like Coca-Cola, like coffee. Okay, really dark. It'll still be clear, but very dark. Okay, scary looking. Now, I won't discuss the other types of jaundice because we're just talking about jaundice caused by liver disease. So I'll skip through hemolytic jaundice or hepatocellular jaundice or obstructive jaundice because jaundice is jaundice. So when you see jaundice, what do you automatically attribute it to? Liver disease. Okay, so is it an early though or a later sign? Okay, later sign, but it is present in acute episodes. So for instance, when we get to hepatitis later, it is one of the acute symptoms, okay, in hepatitis. All right, next topic is, or next complication from the liver disease, from cirrhosis, is portal hypertension. So what does this say? What does this mean? This is simply saying there's hypertension in the portal circulation or in the liver circulation. As you know, what do we call the blood vessels in the liver? Portal vein, the portal artery, right? Okay. So portal hypertension means because you shrunk the liver, you cooked it with alcohol, biliary obstruction, or hepatitis disease. You shrunk the liver, you destroyed the tissues, including the blood vessels running through it. So since think of it as, let's say, the Midtown Tunnel. So if the liver is the Midtown Tunnel, so what happens to traffic that's entering there trying to cross the river? there will be congestion, right, of traffic. Same thing here for the blood. So what will result if the congestion, because this is not actually cars, this is actually blood, correct? And when the veins hit their limit as to the amount of blood they can hold because of the chronic congestion, so what will form? Besides that, because this is slow over time. So what will happen to the veins in the legs, in the rectum, in the esophagus? We call those varicose veins, right? Okay, so in the case of the esophagus, we call them esophageal varices. Varices basically are varicose veins. Okay, now the veins, when let's talk about the esophageal varices, because this is one of the life-threatening complications of liver cirrhosis. We have, so this, let's say this is Yannick's esophagus. The varicose veins are not outside, they're in here. Okay, so this is where her, what did you have for breakfast today? Nothing. So what did you have for dinner or lunch yesterday?
Oh, chicken and rice.
Okay, so this is where the chicken and rice goes. So as she swallowed the chicken and rice, they went through here along the varicose veins. So let's say this is the chicken and rice, and there are varicose veins here. So let's say she put some hot sauce in there, some sriracha, or and then added some Tabasco and then some Frank's Red Hot. What will happen to those distended varicose veins? And they rupture. Yes. Okay. So they can rupture. Can that cause bleeding?
Yes.
Yes, massive amounts of bleeding because the size of the varicosities are this big. So a blood vessel this big, rupture that. Is that a little bit of bleeding or a lot? A lot of bleeding. So bleeding is one of the life-threatening complications here. We'll discuss that separately. So any question on portal hypertension? So management here, of course, does this require treatment? Yes, we would need, because it's hypertension. So what would be your suggestion? What would be a drug that can reduce blood pressure in the circulation to dilate those blood vessels? Can we use beta blockers? Yes. So propranolol will be used. That's a most frequent choice for portal hypertension. And then let's stay with portal hypertension. There are consequences here when you have portal hypertension. So if the blood pressure is so high here, what happens to blood flow? Okay, it will decrease, right? Because again, you've shrunken the liver, so there's heavy traffic. And then, like we said, there will be fluid accumulation in the belly. Okay, we call that ascites. The problem here is, yes, the belly gets so big, like the patient is 9 months pregnant. But unlike pregnancy, wherein how long did the patient get to 9 months pregnant? 9 months. This patient with cirrhosis got to 9 months pregnant size in just a few weeks. Okay, so that's the problem. So now the distension happens so fast. So therefore, who remembers their pregnancy? No, the 9 month. Were you still breathing normally? Who are mom? No mommies here.
No, I don't believe, no. Like I had, no.
No, like when you walk upstairs. Okay, so it's hard, yeah. Okay, so same, no different from these patients. So it'll be hard to breathe. Of course, they'll have to go to the ER or call 911 when that happens. Okay, so they have ascites, and then never mind the legs, the edema in the legs, right? So the legs are swollen, but of course the patient is more concerned about breathing, correct? Okay, so that's one of the consequences here. And they may also have some hemorrhoids, but of course hemorrhoids are not really life-threatening. Yes. We're just talking about the inferior because the superior is from the head, arms. They're not affected because there's no liver up there. So we're just talking about the inferior vena cava because that's where the problems come because that includes the liver. Okay, so the rest of the body, of course, when I'm not saying that blood from the upper part of the body never went through the liver. Of course they did, right? Okay, it's just this blood when they come from the lower, okay, then the problem results, right? Okay.
In this picture there, the inferior would be.
Right here, this one.
That's the inferior.
Yeah.
Where's the other one at the bottom of the liver?
This one?
Yeah.
It's the portal vein.
Portal vein.
Yeah. Yeah, this is not the heart. It's the liver.
So the portal vein jumps into the inferior.
Correct. Any question about portal hypertension? All right, so let's go from here. So now the patient develops ascites. Okay, so yes, the peritoneum is sterile. However, there should only be a few millimeters of fluid there for lubrication. Remember, the GI tract is dirty, but the peritoneum encasing it or covering it is sterile. Right? So therefore, if you put more fluid there than normal, could there be contamination? Yes. So this fluid can get contaminated. This can cause peritonitis and then eventually sepsis and then septic shock, then death. Okay. So this is a slow accumulation depending actually on the severity of the portal hypertension. So the worse the portal hypertension is, the faster the ascites will form. Right? So earlier in the disease, the ascites may develop over several weeks. Okay, but for advanced disease, they could have ascites every other day. Okay, meaning they have to come to the ER to get it drained 3 times a week or sometimes daily. Right? We'll get to management of that in a little bit. So here, what is in this fluid? This is basically from the bloodstream, correct? This water from the bloodstream, which leaked out of the venous circulation now and into the peritoneum. So that's what it is, albumin-rich fluid, 20 liters or more, right? This could be, of course, we weight 20 liters. I mean, imagine carrying, of course, around 5 to 6 liters, this patient needs to be tapped already. The patient is already very short of breath. They cannot stay at home. And then, never mind this one, because this will mention other causes of ascites, meaning not all patients with ascites have liver disease. Okay, there are other causes. Manifestations, of course, the patient looks pregnant. And because the stretching of the skin happened in a matter of weeks, you see stretch marks in a patient with a pregnant patient who had 9 months to increase the abdominal girth. But this one, in a matter of a few weeks, so what will happen to the skin? Stretch really fast. So what will it look like? So you see veins, right? Not to mention stretch marks, but you'll see veins there, right? So veins will be visible. We call them spider veins, okay, over the all over the abdominal area. No. So we have umbilical hernias can also form because of this. Now let's go to management. So how do we help the patient? So the options are, number one, dietary modifications. We'll restrict the patient's sodium intake. Pharmacologic therapy through diuretics, bed rest. This is not only for ascites. This is basically anyone who has a liver condition, whether it's hepatitis or cirrhosis. We place the patient on bed rest. And what are consequences whenever we place anybody on bed rest? Blood clots, yeah? Blood clots and skin conditions. Another option is to drain it, paracentesis, or in the case of end-stage liver disease, we'll talk about shunts, okay? We'll talk about each one at a time. Nutrition, as I said, will control the patient's salt intake. So just like heart failure, the strictest one is 2 grams sodium. Now, of course, is anyone happy of overnight? Yesterday, I was eating a burger. Now, no more burgers. Okay, you're restricted to 2 grams for the whole day, not per meal, for the whole day. So a bag of chips easily has about 3 grams of sodium, right? So You can't even have a bag of chips. Or if you eat a bag of chips, spread that over the entire day, right? So that's the amount of salt you're allowed. So we resort to salt substitutes or other food flavorings so they will continue to eat. Because otherwise, will you eat? Have you ever had rice cakes? No, those sold at. Do they taste anything?
No.
No, like
It's like.
paper, right? Okay. So same warnings as in heart failure. So here, most salt substitutes contain potassium. And again, who are these patients who get liver cirrhosis? Alcoholics. So is cirrhosis their only problem? Will they have heart disease as well? Okay, so most likely they have heart conditions for which they're also taking medications, right? Okay. Okay, so besides dietary control, let's go to drugs. Diuretics will be prescribed. As to which choice, that's not our problem. That will be the doctor's choice, which one, whether it's the potassium wasting or sparing diuretics. But you're responsible again for the side effects. We won't repeat it in this chapter. For any patient on diuretic therapy, of course, because we're talking about fluids, right? So the objective is for the patient to lose fluids, okay, to reduce preload in the case of heart failure, in this case, to reduce the ascites, yeah? So therefore, daily weight is a major way, because can we tell the patient strictly to save urine? Not all patients are compliant, yeah? So therefore, we rely on weight. How much is the weight again? 1 pound lost or gained is equal to 500 ml, right? What about 1 kilogram lost or gained? 1 liter of water. Okay, fluid restriction is not attempted unless no sodium concentration is very low. Meaning if they go into hyponatremia, then we start fluid restriction. Okay, bed rest, as I already said, because the reason we put on bed rest is how will the liver heal if you keep activity, right? Because with activity, you're using protein, correct? And with what happens again when you use protein, you're making the liver work, okay? So therefore, put them on bed rest, because otherwise your therapy will be ineffective. Next, paracentesis. This is now invasive. So we will put a needle into the peritoneum and then drain fluid. So imagine your abdominal cavity. So you have your stomach here, your bowel, small bowels, your large bowels, the spleen, and then the kidneys are somewhere in the back, right? And then you have your bladder at the bottom. Yeah? Okay. So where will the fluid be? Are they in one spot or scattered all over the place? All right, scattered all over the abdominal cavity. So where would be the best place to stick that needle? Up here or down here? Okay, down. In Asia, so I'll just give you an example. So I was able to observe my brother do this. So his favorite area is the umbilicus. So he'll just put the needle there and then attach a three-way stopcock, which is like a faucet, basically. So he'll just open and close the stopcock to drain the fluid. Okay? Meaning he has to stop because once you have the one bottle, because the vacuum bottles are only 1 liter. So after you drain one, of course, you have to stop, right? Close the stopcock or the faucet, stick another vacuum glass bottle, and then continue, right? So, of course, this is in the third world. It's not the practice here. So here, they use ultrasound guidance or fluoroscopy. So we have to visualize where exactly are the largest accumulation, the largest pocket of fluids. So that means they maximize the procedure. Okay, because you can't tap everywhere, right? There's too many holes. You just tap one section, and then if let's say you want to facilitate movement, we'll just have the patient move around, okay, to mobilize the fluid, then we drain it. Because it's down here, what's the organ closest to that section there? The bladder. So your responsibility as a nurse would be, because you're the one sending this patient to the procedure. So what's your number one concern? emptying the bladder. So besides taking a weight, of course, you take a weight because we want to compare how much was removed, okay? Because remember, there will be shifting of fluid, correct? Because although this fluid, where is this fluid located? Is it intracellular, intravascular, or in interstitial? This ascitic fluid here. It's interstitial, right? It's not in the cell. It's not in the bloodstream either. It's somewhere in between, right? But when you drain it out, remember this is albumin filled also. So therefore, will there be changes in the osmotic pressure in the patient's body? This will cause rapid fluid shifting as a result. So what will happen to blood pressure here after the procedure? You drop, okay, even though you did not lose fluid from the intravascular compartment, okay, because of the change, rapid change, because the removal of the fluid is less than an hour. That's how fast you remove up to 6 liters of fluid. So of course there will be osmotic changes. So rapid shifting can affect blood pressure. Okay, so watch for hypotension here. And another thing, because this patient was on bed rest, so what do we automatically institute? No, bed rest. DVT precautions, which can be mechanical or pharmacologic, right? Let's say it was pharmacologic, meaning we used Lovenox, low molecular weight heparin, or regular fractionated heparin, or any oral anticoagulant. Yeah. So what will be you initiate? Your patient's going for paracentesis tomorrow involving a large needle. So what will you ask for? Do you want to give the anticoagulant?
No.
So what do you do? Can a nurse hold a drug independently? You need an order, right? Okay, so call the doctor, ask them, hey, do you want to hold the anticoagulant for today, right? And always it's, yes.
What if you order already in the computer from the
Well,
doctor
sometimes
online?
doctors do that, if you have a good doctor, they because we shouldn't have to, right? They should really initiate that. But sometimes they don't. So it's up to you now. You're the RN, you're the patient's advocate, you're responsible, you pledge on that, okay? You take care of the patient. So you initiate, okay? So it's gonna cause harm, patient might bleed, okay? So you ask for the order. Now it's routine that the patient's ascitic fluid, the fluid they drain, some of that have to be sent for culture. Okay? We want to see if there's already bacterial contamination. Then we'll put the patient on antibiotics because we can't risk peritonitis. Yeah. I already mentioned the volume, so we could remove 5 to 6 liters. That's a lot of fluid. That's how many ml? 6,000 ml. So how much weight is that? 3, right? Yeah, 3 kilograms. Or no, sorry, 3 pounds. Yeah, 3 pounds. Oh, sorry. 6 kilograms. Yeah, because it's 6 liters, 6 kilograms. If the patient because remember, this is not just water, yeah? It contains albumin. So does the patient need albumin afterwards? Okay, not all the time. It's not routine, but some patients may receive an order to receive 1 or 2 vials of albumin. It's just a small, remember your Alteplase bottle? Yeah, so albumin comes in glass bottles. So same size, 100 ml. So you infuse that, okay? So you may receive up to 6 of those small bottles, and they infuse like in less than 30 minutes. So this will help restore your patient's albumin as well as restore blood pressure, stabilize blood pressure. Now, for patients in advanced disease, because they have repeated bouts of ascites, too frequent now. So if the patient requires, let's say, paracentesis once a month, that's fine. They can handle that, yeah? But if this patient has advanced disease already, let's say pre-departure, they're given a few months to live, Do you want them really to undergo a paracentesis every day or even 3 times a week? That's no way to spend your last days. Yeah. I mean, we want to make the patient comfortable. Okay, this is advanced disease again. So this is an option. We don't do this because there are consequences related to tips, meaning it's not really a good idea because this will actually precipitate or if not worsen encephalopathy. We'll discuss encephalopathy in the last part. So this is an option. TIPS stands for transjugular intrahepatic portosystemic shunt. So this is, what's the indication again? Assisting with paracentesis. So you don't have to put the patient on paracentesis repeatedly. So you just do this instead. So this is the description. I'll just describe it using the illustration. So this is what they did. So remember, this is a diseased liver, yeah? So there's very constricted blood vessels there, right? Because of you cook the liver. So instead of, so to manage portal hypertension, because portal hypertension caused the ascites, remember? In addition to low albumin, correct? So those two factors resulted in the ascites. So instead of allowing blood to flow through their normal channels, which is, of course, in this case, heavily congested, right? So they'll put a big shunt bypassing the liver altogether. So the shunt is placed from the top of the inferior vena cava, then all the way to the portal vein here. So totally bypassing the liver. So blood, instead of passing through liver and liver tissue, no more. Goes straight into the inferior vena cava. So blood never touches the liver anymore. So will this improve portal hypertension? Yeah, there is no congestion to speak of. So what happens to the varices and then ascites and then the edema in the legs? What happens? Nothing to speak of. So the patient will have good blood pressure. The consequence is, remember we said that even if this is a diseased liver with 5-10% or less function, it will still work. Here, you're bypassing it. So is ammonia being removed at all? No more. So what will happen to ammonia levels right after TIPS? Starts growing faster. Okay, so this will actually precipitate encephalopathy. Okay, this will make ammonia levels worse. So that's why, is this a first choice? No. When nothing else can be done, no, what are management of ascites again? Diet modification, bed rest, diuretics, paracentesis, yeah? Nothing else works. They're doing it frequently, too frequent for that matter. TIPS is presented. Okay, so we show this to the patient. Do you want this? All right, so this is last resort. And we tell them, of course, what happens is your ammonia will rise. Okay, so this is a consequence. Say yes, okay, we'll proceed.
Will the jaundice go ahead?
No, because I mean the jaundice is because of there's no bile. Yeah. Okay.
So you did walk around yellow.
Yeah. Amarillo. Okay. Okay, so after the shunt, then the patient will have to, the discussion for encephalopathy is in another page though, so we'll get to that, including diet modification after TIPS. Okay, so the varices. The management here is similar to peptic ulcer disease bleeding, meaning we're on 2242. Because this patient will bleed. So which brings me to every patient, therefore, admitted with liver disease, with cirrhosis, assume that they have esophageal varices. Let me repeat. Every patient with cirrhosis assume they have those varices already. So what do you always monitor them for? Bleeding. So same bleeding, GI, upper GI bleeding you talked about in peptic ulcer disease, same exact management. However, there will be an addition here. Okay, one new drug will be mentioned in the management. As far as manifestations, is it really different from hypovolemic shock? The same. So blood pressure drops, heart rate increases, and what happens to the patient? Vomiting blood. Okay, vomiting violently blood. And can they aspirate? Okay, so consequences related to frequent vomiting of blood. Of course, hypovolemic shock will set in. So when the patient comes in, even if they come in for something else, but we know, oh, they have a history of cirrhosis, it's always evaluated. So they always evaluate. So in the CAT scan, for instance, they'll see, okay, so what's the size of the varices? Okay, or if needed, they'll do endoscopy to monitor the varices. Then they do endoscopy while they're there. If they see, oh, this one's really big, so they'll clip them or band them, okay, to prevent bleeding. Meaning they'll wrap it with something to prevent the bleeding. Okay, but doctors decide that. So very high mortality of GI bleed in these patients. So if you're ever going to choose something you want to die from, don't choose this. Okay. So let's say you have a sucky life, for instance, don't turn to alcohol, right? Or drugs. It's the worst thing you can do. You go for a gun or something, okay? Like a knife, for instance, all right? But not this one, okay? Yeah, this is way too complicated, all right? You're killing yourself really slowly. It's not helping. Okay? You're developing other problems. I'm saying that because of my uncles and cousins. So I told the other group this also. Escarda is my mother's last name. All my uncles, all her brothers and sisters, didn't matter whether they were male or female. Same thing for my cousins. Male or female cousins, they all died like this. They all have drinking problems. Okay? Different stories. Okay, different. Each one has a unique story. It's not always about women and stuff. Okay, but mostly women. Okay, their stories: Benjamin, William, yeah. So and Tote, and also Tote and Baby. I don't know their names. Yeah, Tote. I don't know what Tote's name was. And then um, Baby. I think that was his name. Yeah, because back then we had problems with the registry, because when you have a child born, right? We put baby and then your last name. Yeah, yeah, baby Medi. Yeah. So it's all messed up that they put that. So when the people from the register, civil register come in and ask for the name because they want the birth certificate, right? And then there's nobody to ask. What they do is, we'll just put the baby and then let them figure it out, Yeah. So that's what they did. It was really messed up. So anyways, they all had drinking problems. And I remember growing up, so I went to their houses, right? So as a child, I saw them at their deathbeds. They all looked the same. That was my memory. They all looked yellow. They had big bellies, really squishy extremities, and bedbound. Okay? And when I touched them, they go, ow, ow, because they had encephalopathy already. Right? I saw that growing up until I was 10, 11 years old. And because I didn't know, right? I mean, they don't tell 11-year-old, drinking. They don't tell me the story. I found this out in nursing school, but oh shit. So I figured it out. So that was that's what they died from. And then I knew the stories, now as an adult. Okay, I heard they told me now, okay, what was William really, William's wife. So I heard the stories now. Oh, that's why he would, okay, and then it made sense. I would start their day with a bottle of liquor, right? Before they went to work. But at least they were able to function. Remember? Yeah, they're drinking, but they went to work, right? Anyway, back here. So just my advice, okay? So you don't want this, all right? It's too many painful complications. So here's your education for this is ascites kind of late. So let's just go through this. Let's start with the bleeding. Okay. So when your patient has bleeding, of course, what is the treatment? So come in, active bleeding. What do you expect to give first? Fluids, yeah? Okay, so acute GI bleed, fluids, and then followed by blood products, yeah? And then what drugs are given to, slow or stop the bleeding? It was PPIs, yeah? Yeah, remember peptic ulcer. Okay, so we give PPIs or H2 receptor blockers, right? Okay. And then another drug, there's a new drug here you haven't heard of maybe is, okay, let's just go down the list. So endoscopy, once the patient is stable though, we don't go sending the patient to endoscopy, they won't take the patient, okay? They have to be stabilized first. The bleeding must stop before we send them. So endoscopy, this is for, let's say they're not bleeding yet, all right? So they have varices, like I mentioned earlier. So when they see the varices, okay, if they're ripe enough to, to probably bleed, they'll put bands around them, clip them, whatever the doctor decides. Okay, the management, like I said, patient is actively bleeding, so we put them on the ICU. So we give fluids, blood transfusions. Now the drug we use is called octreotide, or that's vasopressin. Now this comes in a small vial, a 1 ml vial. If you're mixing this yourself, this is refrigerated. So in your Omnicell or your Pyxis, you take this from the refrigerator, you mix it in 250 of dextrose or NS. I'm not sure which one. So you dilute it and then infusion, continuous infusion at I think 25 micrograms per hour. So that's about 5 ml per hour. Okay, so really slow infusion. So what does this drug do? It's a vasoconstrictor, but it's targeted though only to the GI, right? It's not like norepinephrine, wherein it's used to manage shock. This one is only for to slow down the bleeding in the GI tract. Okay. They can also use this drug sub-Q if you have like diarrhea, like chronic diarrhea. Have you heard of this use? Because it's a vasoconstrictor again for the GI tract. So if you vasoconstrict, so what will happen to peristalsis? Kind of slows down. Yeah. Okay. So same idea. um, it's generic. I mean, sorry, the brand name for octreotide is called Sandostatin. It is not a statin. Are we clear? I don't know why they picked that name, but I guess because it's an analog, it's a synthetic form of somatostatin. Okay, this is the hormone which causes vasoconstriction. Because of that, I guess they came up with the name Sandostatin. But not to confuse you, this is not a statin drug. Are we clear? All right. So that's what octreotide is used for. And these are the side effects. There you go. Mild hypoglycemia and abdominal cramping or bloating also. So that's the drug we use. Beta blockers, of course, helps the portal hypertension, yeah? So this will help decrease the varices. Okay, so indirectly, this will help. For patients actively bleeding, so when they come in the ER, so let's say they're violently vomiting blood. Okay, so there's blood all over. So imagine the scene, okay? So you have a patient in plain clothes vomiting. So they started vomiting at home somewhere. They come to the ER through the ambulance. So the ambulance is all bloody, right? So they enter your ER, all bloody, nonstop vomiting. So what they'll do is insert a catheter, a balloon tip catheter called a Sungstaken Blakemore tube. Let's just call it a EG tube, esophagogastro, esophagogastric balloon tamponade. So this is what it looks like. It's a huge catheter. So insert it through the nose or through the mouth. It's big, okay? But imagine, how does the patient look when they came in? Bleeding, all right? Vomiting blood, violently bleeding, okay, vomiting blood. Then you're gonna insert this to stop the bleeding. So it has two balloons. The balloons are here at the distal part of the esophagus and also in the antrum of the stomach, because that's where the varices usually form, right around here and up to here. So there are two balloons, and then we of course take an x-ray to see proper placement of the balloon. So this will compress the bleeding varicose veins. Okay, to stop the bleeding. So this will be in for 24 to 48 hours. After that, we take it out, send the patient to endoscopy, and then fix it permanently. So this is just an emergency. This is a rescue procedure, right? To stop the patient from bleeding. Then once stable, then we send them to endoscopy. Okay, but it's not a pretty picture when you see this thing inserted, and whether it's inserted through the nose or the mouth, it's a huge tube. So what's your concern? Aspiration, right? Airway obstruction and even aspiration, okay? Especially if it's through the mouth. So you still want to die by cirrhosis? Choose something else, right? Do it quick.
So what happened to the liver transplant? What happened to the liver transplant?
No, I mean, we're talking about something else, like dying and stuff.
Yeah, I know, but did it not fit as a treatment?
Where do you find a liver donor in the street? Go find one. Okay, so there's a long list, all right? Good thing there's a living donor now. So if you want, you can actually donate a piece of your liver. Okay, not the entire liver, just a lobe.
Yeah, because it grows.
Yeah, go ahead, go. Go ahead though, go outside. Put up a sign, liver donor, all right? You understand what I'm saying? Well, you brought it up.
I know, but
That's what I'm saying. It's not easy, all right? It's not easy.
you know, like it's donate.
Okay. Any question on the EG balloon? Okay. So here's a warning, again, reminding you, what's our number one concern? Aspiration. Okay, so they're usually in ICU. Okay, because again, especially if they have the tube in the mouth, so you have to suction frequently. Okay, so that's why they're in ICU. They need frequent suction. You can't do that if they're in any other place because we have other patients there. So this requires one-to-one. And this one, since we have nothing to do with this, the doctor performs sclerotherapy. So this is all done in the endoscopy center. So they go to the endoscopy and then the doctor will administer sclerosing, same medications they use to destroy varicose veins in the legs. So same idea. And the ligation and banding, again, we don't have any role in that. That's the doctor does that. We'll skip. We have no role over that. And we already discussed tips. Okay, so let's discuss now the therapy after tips. Which is in encephalopathy, I guess. Yeah, okay, right. It's on the next page. Okay. All right. The complication of encephalopathy is, of course, coma. The patient goes into a coma, which is what happened to all my cousins and uncles. Pretty predictable. So this is, again, the life-threatening complication of liver disease because now the patient has blood poisoning, basically. Okay? Ammonia levels are so high. There are 4 stages of this. So ammonia is the major cause, the high levels of ammonia. So here's the ammonia enters the brain, excites the peripheral benzodiazepine type receptors, And then basically the nerves get very irritated. They're irritable and then causes brain damage. So the only way to treat this is what? Since it's ammonia, so therefore, what do you control? The ammonia. You have to remove it. Now, the easiest way to do it is through lactulose. You give the laxative lactulose up to 3 times a day. Our goal, this is the manifestation, by the way, asterixis or flapping tremors. This is elicited by you. I just ask the patient, okay, hold your arms up like this. If their hands do this, that means they have nerve irritation already in the brain. So they'll have asterixis or flapping tremors. This is seen in stage 2 and up. And they also have this bad breath. The breath actually stinks like crap. It smells like feces. That's why they call it fetor hepatitis. Talk about bad breath. We've seen had bad breath. This is bad breath, right? Okay, so the objective is to eliminate ammonia. Since the liver can't do it, then we have to eliminate it through the GI tract. So that's where lactulose comes in. So you've seen it, right? It comes in a plastic cup colored yellow, orange color. So you can give it through, the patient drinks it, or through an NG tube, a feeding tube. It doesn't work through enema. Unlike KX-Late, where you can give through an enema, this one you can't. It has to be swallowed. So the objective is to produce 2 or 3 soft stools per day. Now, because this is chronic therapy, is given every day, some nurses forget the goal. What's the goal again? 2 or 3 soft, right? Soft. Okay, doesn't say diarrhea, does it? No. We can overdo this sometimes because the standard is, of course, the doctor will order 3 times a day, but it's now your judgment to continue with the second or the third dose. Of course, if the patient already had 2 to 3 after 1, is it necessary to give the second and the third? No, because we've met our objective. Okay, so as long as the patient made 2 to 3 soft, okay, soft BMs. If it's hard, do we stop? Give the next doses, okay? So because what do we want? Soft, how many? 2 to 3. Okay, so if you receive 2, if you achieve 2, is it good? Yes, you've met your objective. So of course, just tell the doctor, okay, okay, I'd like to hold the second and the third. Patient already had 2, right? So you take the initiative. Don't continue giving it. Then the patient's now having diarrhea. Okay, that's not right. Okay, these patients already have these major problems. You don't want to add diarrhea to the symptoms. Okay. So here's the warning about that, because you can overdo it. Again, the problem is because this is given chronically. So the patient is given this forever, basically, pretty much. Okay, the rest of their remaining life. Another way, of course, is lactulose enough here, or do we need to modify the diet? Yes, because where did ammonia come from? This is from protein, okay? So this is a waste product from protein. So what do we do with the patient's protein level? Okay, we have to control it. Okay, so on the next paragraph, here are other options. If the patients don't respond to lactulose, you can use non-absorbable antibiotics, okay, like neomycin, metronidazole, rifaximin. Between the 3, we frequently use metronidazole, okay, by mouth. So this will decrease ammonia-forming bacteria in the colon, right? So that's another option. And while on therapy for lactulose or the antibiotics, these are your monitoring. So neurologic status, right? Mental status of the patient. The handwriting, there's remember that figure earlier? Or in this one. Instead of making a star That's how they draw a star now. And that's their handwriting. So that's how you tell how bad the encephalopathy is. Right? So for nutrition, chart 43-4. Now, don't misinterpret this. The patient needs protein, yeah? The liver is diseased. They need protein. The liver is not making or synthesizing protein normally. So they need protein for tissue repair, healing, right? And then, of course, the rest of the body needs protein too. However, if the ammonia levels are high, does it make sense giving normal amounts of protein? No, not anymore, especially after tips. So now we limit it between 1.2 and 1.5 grams per kilogram of body weight. Are we clear? Okay. So the decision as to how much protein, again, we need tissue repair, we need to help the liver, we need protein for the rest of the body, especially plasma, but we don't want to give too much protein because that would just contribute to more ammonia. That's it for liver disease. Any questions?